Hello JPEG viewers, here we have a 51-year-old female who had previous trauma to her left eye and sustained scleral rupture with uveal prolapse. She underwent scleral rupture repair but eventually developed wound dehiscence. When I finally saw the patient, the area of dehiscence appeared stable, so I decided not to disturb it any further. Now, looking at the anterior segment, the patient has traumatic cataract with an irregular pupil with synechia formation and an extensive fibrous membrane cladding the surface. So I began by creating a side port incision and injecting viscoelastic into the chamber, followed by the main incision. Synechiolysis of the thick membrane was then performed. Next, I flushed the anterior chamber with epinephrine, but of course no avail. I then injected blue dye under the iris, washed it out with BSS, and re-injected viscoelastic. Now we proceed with the incisions for the iris hooks. Now while inserting, I encountered difficulty hooking them in place because the iris in this area is bowing posteriorly, while the opposite side is tilted anteriorly due to the prior trauma. Now I use intraocular forceps to help position it in place. It just feels awkward because of the angle. So I decided to bend the iris hook to better match the angulation, and that worked. You could actually proceed with cataract surgery without iris hooks, but I wanted to have them in place just in case I needed to convert them into capsular hooks, especially in a trauma case like this. Suffice it to say, you don't really know what to expect. I then proceeded with the capsulorhexis. There was no wrinkling or trampolining, suggesting that the zonules are still relatively intact. I decided to sculpt the surface first to debulk the lens, given the somewhat shallow anterior chamber. Now it's shallower than usual due to the tilted disposition of the lens from the trauma. The cataract surgery itself was fairly routine, slightly mushy and sticky cataract, but overall uneventful. While performing INA, I noticed that the posterior capsule looks dirty. Now these are actually pigments brought about by the trauma, which signifies iris pigments from zonular compromise or RPC breakdown products from vitreous hemorrhage. I then filled the capsular bag with viscoelastic and inserted the IOL. Now once the IOL was in the bag, I proceeded to remove the hooks, and there are two ways to do this, either through the main incision or through the iris hook incision themselves. Next, I trimmed the redundant pigmented membranous tissue, and I proceeded with pupilloplasty. I made sure to position the microforceps under the needle while simultaneously tilting the globe with the second instrument. Now this helps avoid inadvertent intraocular tilting of the needle and prevents damage to the surrounding structures. Now you can perform either a Seepster or Macanal technique in this case, but I chose the Macanal technique. I then cut the ends and perform INA to remove the remaining viscoelastic. And this is how the patient looks post-operatively. The patient unfortunately developed sympathetic ophthalmia, but with prompt treatment and good response, her vision improved to 20/40 from a previous fair light projection. Now that was a really close call, but we made it through. So I hope you enjoyed watching this case and learned a few pearls from it. See you on our next post. Don't forget to like and subscribe.